Good morning, everyone, or good afternoon to those of you who are tuning in from the East Coast. I'm Carolyn Wang Kong. I'm the Chief Strategy Officer here at the California Endowment, and I'm excited to welcome you all and to be your moderator for today's webinar, State and Federal Budget Updates, What's Ahead for Medi-Cal and California's Health Landscape. Before we get started, I have a few housekeeping items. First, I want to let everyone know that the webinar is being recorded, and the recording and all of the slides that are going to be presented today will be shared with all registrants after the event. Second, we encourage everyone to engage in this conversation today and submit any questions you might have using the Q&A box that's at the bottom of your screen. We're going to do our best to answer as many of the questions as possible during the audience Q&A portion. And we want to thank those of you that took the time to submit questions in advance. They've been really helpful in helping us shape today's program. Policy Perspectives is a virtual space where we gather with partners and stakeholders for conversations on state and federal issues that impact our state and communities. These webinars are nonpartisan, non-political, and non-lobbying, and they are intended for informational purposes. So our last Policy Perspectives webinar in May happened the day the House of Representatives was voting on the federal reconciliation bill, and in California, our state leaders were negotiating the state budget. Here we are, 3 months later, having a conversation that we wish we were not having. The enactment of H.R. 1 represents a huge setback on the progress our nation and state has made to expand access to healthcare and safety net programs, including nutrition assistance. And as if that wasn't enough, California's state budget also made significant changes that will restrict access to Medi-Cal for immigrants in California. Today's webinar is intended to help us make sense of all of these changes and the new landscape. Our speakers today are bringing expertise at the national, state, and county levels, and they'll be discussing the impact that these policies and cuts will have on our communities. As we hear about all the numbers and dollars and implications of these laws, it's critically important to keep in mind that we're talking about real people. We're talking about families, children, seniors. We're talking about generational impacts to health and livelihoods. So with that, let's get started with the program. I'm thrilled to introduce our speakers and partners who will help us make sense of everything that's happened. I'm not going to go into their full bios. We'll be sharing all of that in the post-webinar resources. But I'm going to first welcome Peggy Bailey, Executive Vice President for Policy and Program Development and Vice President for Housing and Income Security at the Center on Budget and Policy Priorities. The center has played an important role in helping us, the public, and policymakers understand how federal policies and policy proposals impact our communities. We are so grateful, Peggy, to have you join us today. Next, we have Chris Haney, our Executive Director of the California Budget and Policy Center, our key go-to partner on all things state budget. Chris and team has been with us on a number of these webinars, so we're very grateful to have you back again, Chris. You've been consistent and reliable guests with us, so thank you for joining. We're also joined by Lisa Chan-San, CEO and founder of Transform Health, a national healthcare and policy consulting firm. With her years of health policy expertise, Lisa has a way of breaking down complex policy issues and making them accessible and understandable. Welcome, Lisa. And last but not least, Jacqueline Wong Hernandez, who is the Chief Policy Officer for the California State Association of Counties, or CSAC, the association that represents all 58 counties across California. Jacqueline has also held various roles within state government, and we are excited to have her perspective in this conversation. Welcome, Jacqueline. So each speaker is going to go ahead and make some opening comments, and then we're going to go into a panel conversation. After the panel section, we'll have time for audience Q&A. So again, I'd like to remind folks to please go ahead and enter your questions in the Q&A box. So Peggy, we're going to start with you. And we're going to ask you to give us an overview of H.R. 1 and specifically the health and nutrition access provisions of the legislation and any other executive actions that will impact access to health and public benefits.
Great. Thanks, Carolyn. And thank you for having me here today. I am going to do my best to deliver news that isn't the best, at least with a smile, if I can't do anything else. I'm also going to run through this pretty quickly so that we can make sure we have a lot of time. So one resource that you can use is we have all of our resources when it comes uh, to the bill in one place, and I'm going to put the link in the chat. So I'm going to go over a few buckets at the federal level. I'm going to ground us in what actually passed as a part of the reconciliation bill, specifically around health and SNAP. I want to talk about what's happening in the appropriations process and the bigger existential threats around impoundment and rescissions, because that's really where the core public health programs are funded. And then really quickly, mostly as to give you a flavor for things, executive actions that are underway in this space. And you'll have my slides after, so you'll see me whip through a lot of slides, but know that you're going to get those as a resource. And that's why I put a more detailed slide deck together. Next slide. So let's kick things off with, you can go to the next one. Let's kick things off with the reconciliation bill summary. So as a reminder, right, the overall point around this bill is that it paid for tax cuts for wealthy people and wealthy corporations, primarily through cuts to Medicaid and food assistance, and not doing many things in the Affordable Care Act that we could have done, right? Uh, Even in the places where there are so-called middle class tax cuts or credits, they were modest and they're generally time limited. So even in the ways that it tried to do something for at least people further down the income scale, it falls short. Another overarching point is the harm it causes to immigrants, particularly immigrants who most are here lawfully, who were eligible for benefits and now won't be in one bucket, while expending over $170 billion in increased border and immigration enforcement. Next slide. So to whittle down on health in particular, we estimate that about 15 million people will lose health coverage and become uninsured. As I said, this is in two ways, one through Medicaid cuts and one through increased costs that people will experience if they're trying to get coverage through the marketplace. The biggest places that it cuts Medicaid is by restricting uh, coverage to lawfully present immigrants and enacting work requirements as a part of Medicaid. As far as the marketplace coverage, it mostly does this, one, by not including the premium tax credits that people have used to be able to afford coverage, and not including that, but also making it harder to access coverage in the first place. Next slide. And then around food assistance, we estimate that more than 41 million people could lose access to food benefits, both from actually losing access to benefits because they're not eligible anymore and because red tape prevents them from enrolling in the first place. The biggest way that SNAP is now under threat is because the reconciliation bill shifts a ton of costs from the federal government to the states. It does this in two ways. One, it it increases the administrative costs to states, where states had previously paid a 50% of the administrative costs and the federal government paid the other 50%. Now that's going to shift to 75% state costs and 25% federal. The other way that costs are shifted to states is that states now, for the first time, will have to pay some of the benefits. There's a sliding scale as to how much states will have to pay. It'll be anywhere between 5 and 15%, which with some states either having theirs delayed because their error rates are too high. That was what Alaska was given as a part of the bill, and states who have extremely low, which are not many, might could also avoid some costs. But most states will have to pay between 5 and 15%. And again, SNAP is another place where now lawfully present immigrants will not be able to have access to the benefits that they're used to. Next slide. Um, this slide summarizes what is going to happen the to people with humanitarian protections. So I just wanted to put this slide and the next one in the same place, in one place for you. Next slide. Because the child tax credit was also barriers were set up for that for immigrants as well. Where now, if both parents don't have a social security number, the children will lose the child tax credit. And I know in California that's a huge issue because there are so many mixed status families. So that gives you a summary of what is in HR 1 and also tees up for my co-presenters what the states and counties will have to deal with. Next slide. Now I want to go into appropriations and impoundment and rescissions. Next slide. So what you need to think about is sort of two alternate universes. A universe where normal business is happening and we're passing appropriations bills and life is bipartisan and happy. And another very partisan construct where there's existential threats of impounding funds that Congress had appropriated, and a lot of this is illegal and being challenged in courts, and rescissions that are happening. There was one small rescission package, that's the package you may have heard about, that took funding away from PBS as one place that it cut. And that we believe that that rescissions bill is laying a process that the administration wants to use moving forward. So there's these two universes that are happening at the same time. Um, but and so what we're trying to do and what in order to protect the safety net programs is connect these two universes so that we can have normal business happen and the discretionary programs get funded while also protecting them against cuts that would happen behind the scenes that Congress and the administration might move forward. So, um, this is, like I said, critically important because we know that community health centers, substance use treatment programs, maternal and child health services, all the public health stuff happens in the appropriation space. We know the fiscal year always ends September 30th. We rarely ever have bills by then. So we'll start this whole government shutdown clock um, and such starting in September. We expect that continuing resolutions will happen to an extent, but we expect either that Thanksgiving to Christmas time to be a critical moment where we could face government shutdowns if the programs aren't protected, or like in the past, that February to March spot has been really dicey. But it's really important to think about these things together because you can't have an appropriations process that goes through normal business and pretend like there are other actions that are happening behind the scenes that are restricting how dollars get spent, which also includes the reductions in force of things that have been happening. Because if there are fewer staff, you're not able to spend money. Next slide. So the next piece that I want to, and after I'm done, I'll put in the chat a link to the executive actions page where we have an executive actions tracker. So the executive actions around health. Next slide. So these are things that that are coming out totally out of the administration and aren't going through Congress. You can see this list of potential executive actions, mostly through guidance and regulations that are happening in Medicaid. I'll point to there are several, especially around immigration, and one that's important for California and the waivers that the state has is the rescinding of guidance on the health related social needs piece and the housing and food waivers that California has and where the federal government has been paying part of that. Next slide. There's also this big program integrity rule that's happened in the marketplace. We thought that maybe it might get codified as a part of the budget reconciliation bill, but given the reconciliation rules and other things, they didn't try to do that. This slide explains sort of what this program integrity rule will do to the marketplace coverage, the changes in premium thresholds, and other provisions and things that and it could have really wide reaching of impacts on how people are able to access coverage through the marketplace. Next slide. And then these are a couple of others. Like I said, you'll get in the packet. Next slide. And then the last thing I just want to focus in on is what is happening to immigrants as a part of the federal benefit. And this is, of course, important to California because the next slide, because whatever the federal government isn't paying for, the state will have to pick up. So what has happened is the administration is trying to redefine what federal public benefits are, make that broader, and which will make certain people with certain immigration statuses not eligible for those public benefits. Generally, especially in the public health world, people who are we didn't check immigration status. Now programs are going to have to, because they're going to have to see if they're in this qualified immigration status bucket in order to receive services that normally we wouldn't do. We wouldn't restrict. So this slide explains what the federal benefits are. And next slide. And this explains who might be applicable. And like I said, the biggest thing for this audience is the top slide, where there are about 13 programs in the Department of Health and Human Services, including community health centers, Head Start, Title X family planning funding, that now people would have to meet this threshold of being a qualified immigrant to be able to receive federal public benefits. And with that, I will pass it back to Carolyn.
Thank you, Peggy. Thank you. A lot to take in there. Thanks very much for that overview. It's helpful to hear about the two universes. I think we're living that, but naming that is helpful. So we're going to now zoom in on California, and we're going to go to Chris. So Chris, the state budget was signed before HR 1 was enacted. So can you please give us an overview of three things? So the implications of the California budget as a result of HR 1, the health provisions in the state budget, and what's ahead in the budget process.
Great. Thank you, Carolyn. And thank you, Peggy. It's great to be here with all of you and our national partners at the Center on Budget and Policy Priorities. So yeah, I'm going to try to answer those three questions by telling you about what's happened in California with the state budget and what happens, and a little bit of a picture of what we think happens next. Next slide. So as Carolyn was setting up, the key context here is that there are three things that happened. Actually, we need to go back one. So there are three things that happened overall that the state leaders enacted a state budget at the end of June on their normal timeline. Federal leaders then enacted HR 1, or the reconciliation bill that Peggy was just talking about, on July 4th. State leaders aren't done yet with their budget, even though we enact a budget by July 1st so we can start a new fiscal year. There's always a set of adjustments to the state budget that happen in the couple of months that follow. And so state leaders are back in session right now, and there are some adjustments to the state budget that they can make. There may be a few things that they do to try to respond to HR 1, probably only smaller, more incremental types of things, and most of their response will have to come in the next year's budget cycle that'll launch in early January. So that's sort of a sense of the timeline. And let's talk next about what happened at the state level, and then I'll try to weave in some of the implications of HR 1 for the state. So next slide. The key thing to know here is that the state leaders themselves had to close a budget deficit. So they had to do that in a few ways. That budget deficit emerged from economic effects like the Trump tariff policies that were gradually taking effect. There are also effects of rising Medi-Cal costs for Medicaid or Medi-Cal in California that state leaders were having to deal with midstream before all of these other cuts. And so those things drove us that they responded to by cutting spending for some essential services, particularly in Medi-Cal and particularly for Californians who are undocumented. They also used some of the MCO tax money that was raised to actually help close the deficit, and that means that money didn't go towards its healthcare purposes like reimbursing providers. And then they increased a loan that they made back in March in order to Cal having the state costs and building the deficit up a bit. The budget deal notably doesn't include any major tax policy changes to close the deficit. They didn't put any new revenue policies in place to try to avoid state spending cuts, and they didn't buffer anything against federal cuts so far. Because the bill hadn't HR1 hadn't been passed. So we'll go to the next slide. The big picture, of course, in HR1, Peggy has already covered, which is that HR1 gave away trillions of dollars of tax giveaways to high wealth individuals and corporations, or primarily to those folks, and then cut Medicaid by about $1 trillion, SNAP by $186 billion, and increased the money for the deportation and detention agenda that we've experiencing, particularly in the LA region, but also in other regions here in California. So I want to talk specifically about some of the provisions in the federal HR1 bill, going to the next slide, and what those mean for the state budget. And you can go to the next slide as well. Thank you. Um, so as Peggy started to outline, there are a whole set of cuts to Medicaid that are where there's a whole bunch of new red tape, burdensome red tape, forcing adults who were in the Affordable Care Act expansion population to prove their working, looking for work, or participating in job programs. Where the estimates of the potential hit to California that are about 3.5 million Californians could lose their Medi-Cal coverage as a result. There's also a requirement that there are new eligibility checks every 6 months. The current or the prior policy had been 12 months. So now another way to kick people off the program by putting new burdensome requirements in place. And then there were exclusions for certain immigrants from Medicaid and the Children's Health Insurance Program. This is previously lawfully allowed to access the benefits are no longer being included. There's new $35 copays for people in the ACA expansion population whose incomes are 100% above the federal poverty line. And then there's also a set of new restrictions on the state's ability to use MCO taxes to produce revenue for healthcare purposes. And then, of course, there's reducing funding for all of the preventative, primary, reproductive, and sexual health providers. So this is the defunding of Planned Parenthood sits within this category. So that is all of the stuff that's going to hit California in terms of people who are eligible for Medi-Cal and the funding that flows into the state via HR1 in terms of Medicaid. Now, the next slide also talks about the effects on the marketplace, or what we call covered California here in California. And there are hits there as well. As Peggy was mentioning, the enhanced premium tax credits that enabled people who make just a little bit too much money to qualify for Medi-Cal were getting tax credits to offset the costs of the marketplace or covered California. Those tax credits were allowed to expire. That means about 1.8 million Californians could face higher premiums, and about 400,000 will likely lose some coverage due to the cost of those high premiums. There are also they're ending the marketplace subsidies for a set of lawfully present immigrants, continuing the story that Peggy told about the changing conditions for immigrants, where that's going to affect about 112,000 covered California enrollees right now. And then there are penalizing people by who have fluctuating incomes which means they go off and on of eligibility for covered California. And if they received a tax credit, there were some protections in place that if they ended up making too much money at the end of the year, there were protections so they didn't have to pay that back. They're now removing those protections, which means that folks may be having to pay the federal government back or the state government back for the costs of having received a tax credit. So that's what's happening in the marketplace arena. I want to then talk next about what's happening at the state level. And I wish I had better news to share here, but because of the state budget deficit, there are some things that the state did that are not good news in the healthcare arena, particularly for Medi-Cal. So one of the ways that the state closed the deficit was to remove some benefits for immigrant communities. So they have will start to freeze Medi-Cal enrollment for Californians who are undocumented and between the ages of 19, or sorry, who are 19 and older. That starts January 2026. So everyone who enrolls before then is in, but there's no more enrolling thereafter. They impose a new $30 monthly Medi-Cal premium for certain immigrants ages 19 to 59. That starts next summer, a year from now. And they eliminated Medi-Cal dental benefits for those same immigrant populations also starting next summer. So you're seeing some of the same themes in what state leaders did, unfortunately, to what we saw happen with HR 1. There are also some broader cuts to Medi-Cal more generally, and those I'll walk through those on the next slide. Those are in particular that there's a reinstatement of asset limits. So asset limits are something that restrict people from being able to access public benefits because they have some kind of an asset, like a savings account or a retirement account, or they own vehicles or property or something like that. And we worked really hard for years to get those removed from public benefits in California. But they're reinstating those benefits or those assets at high levels, but it's an unfortunate thing that it happens. They're also ending access to weight loss drugs for people on Medi-Cal and imposing some other changes that may delay care for certain folks. So I've only got a minute or so left here. I want to talk about the food assistance side of it, and then I'll close out. So the next slide will go to the federal part, and that's the main thing I want to highlight here on the next slide, is that the SNAP cuts, or what we call CalFresh in California, have some really significant impacts for the state budget. As Peggy was saying, the cost shift to states, which is unprecedented. In California, that's going to result in our having to pay 15% of the bill for CalFresh, where weren't having to pay that previously. That's going to cost the state $1.8 billion annually just to cover where the program is now under HR 1. It also forces the states to pay a larger share of the administrative costs. As Peggy was saying, that bill for us will look like about $650 million. And then there are another set of these like work requirements, time limits, and other sorts of frozen pieces that will actually restrict people's access to benefits in the program as well. So that's the implications for the state of HR 1 in terms of the SNAP or CalFresh side of things. I'm just going to stop there. A couple more slides about what happened at the state level in terms of economic security programs. The short version is that the state mostly held the line on investments that have made in earlier years, and there weren't any particular cuts that they've made there. So I will stop there. That's the news on the federal budget, its impacts for state budget, and I'm sure we're going to get more details from colleagues soon. And I will share a link in the chat that will have more detailed information to our analysis of HR 1 and the state budget. Thank you.
Great. Thank you, Chris. Okay, so next up, let's bring Lisa into this conversation. So we just heard about changes to funding streams, lots of new requirements, phasing in over multiple dates. On the policy front, we know that there's still a lot of unknowns, but can you speak to what's on the horizon in terms of implementation of these federal and state policy changes, including impact on Prop 35 and the MCO tax as well?
Absolutely. It's a pleasure to be here with all of you. Good morning. If we can advance the slides, please. One more. Thank you. So we know from Peggy and Chris's excellent presentation, back one slide, please. Thank you very much. So we know from Chris and Peggy's excellent that California, similar to many other states, is going to face a reduction in the available program dollars in Medi-Cal, and will need to enact programmatic changes. The Newsom administration has already estimated that they're anticipating HR 1 will result in a loss of $28 billion in federal funding. To put that in context, the current total Medi-Cal budget, including state and federal funds, is about $202 billion. And as a result of it, the governor's office is estimating 3.4 million will become uninsured as a result of HR 1. And so, given this forecast, the California legislature, when it comes back, is going to have to make some really important choices to balance the budget, as Chris has pointed out. In states, unlike the federal government, we are required to balance the budget every year. And so in past budget deficit times, the state really has two options, as indicated on the slide. We can either backfill the lost federal funds, or we can choose not to replace all of the drop in federal funding and operate on a smaller Medi-Cal budget. If we were to backfill, what that would look like, the state will likely need to make some choices around making cuts to other parts of the state budget, maybe draw from reserve. We could also go down the route of increasing revenue through raising taxes. On the other side, if we choose not to replace those federal funds and operate on a smaller Medi-Cal budget, the state is faced with elimination or reduction in the scope of potential optional benefits, reduction in provider rates, restrictions in eligibility, or Medi-Cal cuts could also occur to fund other programs, such as restoration of public health funding. We've heard earlier today the cuts to food programming. So, there's a multitude of things that could happen, and states could also implement a mix of solutions. Of course, nobody wants to make any of these choices, but given the requirement to balance the budget, policymakers are going to have to make some tough decisions coming into the fall. There are some questions around whether we're going to see a special session. This week, we saw the legislature start holding hearings around the impact of HR 1, including today. I'll make a shout out. I know the Assembly Budget Sub 7 Committee is having some hearings around what are the implications of HR 1 on Medi-Cal. We're also seeing the legislature begin looking at what are the implications for other social service programs. So a lot of folks are anticipating that there's going to be more to come. Next slide, please. And many of you will remember in the fall, the state passed and many voters voted to pass Prop 35, a ballot initiative that would raise funding to improve provider rates and make investments in the Medi-Cal program. In what we know right now is the MCO tax, which is the funding mechanism in Prop 35, is not in compliance with HR 1. So given this challenge, DHCS, the state's Medicaid agency, is seeking a transition period from the centers from Medicaid and Medicare. They don't know if we're going to be able to secure a transition period. The transition period would allow us more time as a state to come up with a new approach to the MCO tax and allow us a glide path to transition budget needs around how we fund the Medicaid program here in the state of California. given that it's unknown whether California is going to receive a transition period, we need to talk about some of the contingencies. And so what we do know is it's going to be really challenging under the new HR 1 rules, how the state can develop and structure the MCO and any provider taxes moving forward. So what we've heard from the state in the most recent Prop 35 Stakeholder Advisory Committee is that if we do not receive the transition period, the state is anticipating that the MCO tax would reduce significantly, and the state will likely get about $75 million annually. To put that in context, California is expecting in this current fiscal year alone to receive $9 billion. That's the last bullet on this slide. From the MCO tax. So that is a significant drop from 9 billion to 75 million. And moving forward, we know that we need to restructure the MCO tax to really fit within these new parameters. If we don't get a transition period, the state has indicated that they would like to prioritize the funding that the state does receive through the MCO tax in 4 sequential categories in this order. So the first priority would be to backfill Medi-Cal for any of the gaps. If once that gets filled, then they would use the funds for targeted rate increases for primary, specialty, and emergency care. Once those needs are met, they would redirect funds to reproductive health investments, and then finally managed care base rate increases. At this current time, we are still waiting for further federal guidance. The state is seeking a transition period, and we're unclear where we are there. Next slide, please. So as we look forward, I'm going to end on this slide because this slide maps out key changes and when they will occur. You'll see here in green, this is the timeline of when key provisions in HR 1 goes into effect. The purple blue color are the enactment dates for things that have been passed in the current budget, and orange is key upcoming California budget dates. Many of you will see, we're here in the fall. We anticipate either a special session or continued conversation moving into the fall as the governor develops and the administration develops the budget for presentation in January. And what I want to point out here is while the public won't feel some of these impacts until after the November 2026 midterm elections, state governments, county governments are going to need to start building infrastructure, reworking programs, develop training so that we can hit some of these dates if we do need to move forward in this manner. So a good example of this is the work requirements provision in HR 1. That goes into effect January 2027. There's a lot that would need to be developed around how California would address work requirements. We would need to build some and augment infrastructure and technology systems. We would need to train the folks who are doing the enrollment eligibility work on the ground, as well as provide supports to folks who are having to go through this process. So that doesn't happen overnight. There's going to need to be conversations and planning done to prepare the state and everyone for these, deadlines that are looming. So we wanted to share this and end here because this sort of sums up, some of the key things that we all are going to be faced with as we move forward over the coming months and years. And we're happy these slides will be shared. Thank you all very much. We're happy to take further questions later. And back to you, Carolyn.
Thank you, Lisa. I feel like that last timeline slide is something we all need to just print out and have handy with us. So thank you. So now we're going to shift to Jacqueline. And Jacqueline, so counties play obviously a key role in the delivery of all of these safety net services, right? And you're going to be, counties will be really impacted by all of these cuts to Medi-Cal and CalFresh. Can you start by giving us a brief overview of county governments and their role in the health and safety net ecosystem, and then go into what are the anticipated impacts at the county level and what local elected leaders are preparing for in terms of implementation?
Thank you, Carolyn, for the question. Yes, absolutely. The presentations up to now have been so excellent at explaining sort of what the changes have been and what's at stake. And where I want to take us back a little bit is really about what it looks like in counties now, because I think that we've all been very concerned and understandably so about all of the changes that have been coming, but the baseline wasn't great. I think it's important that we don't forget that. So in California, counties administer the safety net. So they administer the health and human services programs that that really serve our most vulnerable, Medi-Cal, CalFresh, all of those kinds of supports, and some of the most complex behavioral health programs. And this is definitely not true in most other states. And so they do this on behalf of the state. It's the way that our system is structured. And so they're in the business of implementing those state priorities. And so eligibility, administration, provision of direct services. And so prior to HR 1, I mean, we were in a situation, as most of you probably know, where we already had provider shortages, especially in rural counties. But in other counties too, there are low reimbursement rates for Medi-Cal patients and for the provision of services. And so we have providers that limit the amount of Medi-Cal patients they can take. There were long distances to reach care. We experienced people putting off care and not accessing the sort of preventative care that we would want them to access just because it was more difficult. And so when fewer people get preventative care, obviously they end up in our ERs and they end up with more chronic and acute and, life-threatening conditions. And we were also in a space where we have serious workforce issues at the counties, both in the clinician side for things like intensive behavioral health services that counties provide, but also in eligibility workforce, the trained staff who actually make the services real. And we've had vacancies, we've had turnover. After the pandemic, things even got worse and sort of reset in that way. And so again, this is all before HR 1. And we also had in California, we've had Prop 1, we've had Care Court, we've had all of these new programs that were geared toward increased behavioral health, better behavioral health outcomes, increased service provision, homelessness, all of that. And it was during sort of the budget flush years where they wanted to make one-time investments. And so counties are on a path right now to implementing some of those investments that were made in the last, 3 or 4 years. And the counties have been sort of doing more in that space, and they can do that when they're implementing the state priority, and that's what is expected and what's going to happen. There have been unprecedented one-time state investments in those kinds of additional services, but not sufficient ongoing resources. So that's kind of where we started. And in California, we had embraced the ACA expansion, and counties then implemented it. So we moved, it's really important to note that, in the last 15 to 20 years, we really moved toward serving more people and embracing a higher level of commitment to the health of all Californians than we did a generation ago. And so when you're moving in that way, and then you get hit with this sort of about face, the counties experience it in a very personal, community level, because they're implementing and in implementing the state's priorities, but also within federal guidance. And so when the state and the federal priorities and approach really do this, the counties are sort of caught in the middle trying to figure out how do they plan for what's next? And how do they, after you have so many people where we're saying the imperative is we want to serve more people, we want to serve them better, we want to make it easier, we want to get people healthcare, or we want to get people food, food is medicine, all of those pieces, to kind of walk that back, but then not have clear answers kind of around what it will look like. And so that's the primary kind of point that I want to make, that there is all of the uncertainty and the things that need to be determined at the federal and state level, and those are real things that need to be figured out. But as Lisa sort of touched on at the very end, that also needs to get communicated to counties, and we have to train people to implement whatever the new reality is going to be. And when we don't know, that doesn't stop eligibility workers and county line staff from having to look people in the eye and say, we don't know, as people have questions. Because people aren't as dialed in as the policy people, nor should they be. They have their entire lives, and that's what, we're here to serve them. And so it's really hard on the ground. So the other thing I wanted to talk about is uncertainty in general is really hard on any implementer, because it's hard to make a capital investment if you don't know the operational money is going to be there ongoing, or you don't know if the service is going to be provided in the way that you thought, or if the program is going to be eliminated or need to be totally restructured. And so, we know what has come down from the federal government and what the dire consequences could be. But as Chris touched on and Lisa touched on, it also hinges on what is the state's response going to be? Is the state going to take on some of those costs? Or is the state going to say, counties, if you want to keep doing this, it's on you, because your community now expects a certain level of service. So those are some of the things that we're dealing with. I think that Chris's slide about HR1 limiting access to Medi-Cal is a really important one to go back to after this webinar, if you're looking back through the slides, if you're a super nerd like me, because counties have to operationalize these. And I really would love for everybody to walk away with thinking about, what does it mean on the ground, provider to client? Like, what does it mean to have the interaction where you're thinking through how to roll out or how to roll back benefits that people have been getting? And then the other slide that really struck me was Lisa's slide on the state needing to make trade-offs. It was a great slide, and counties are in the same boat. When the state decides what trade-offs to make, it goes back to the counties to say, okay, here's what the state decided to do. If we're now losing funding for health and human services and safety net services, do we divert county resources to that? And if we do, then what is that trade-off within the county general fund? Because counties also do elections. Counties do, vital records, birth and death certificates, marriages. Like, counties do other things beyond the safety net services. And so our counties are really diverse. You have LA County with 10 million people and Little Alpine County with about 1,100, and everything in between. And so it's going to hit all of them differently, as well as their ability to raise revenue at the local level is really different in a wealthier county versus a county with a declining tax base or a small county. And so, counties have emerging concerns around their ability to plan, around for some of them, their entire healthcare system potentially being compromised when patients disappear, and they've built up a healthcare system that was based on an expanded population. So they've built that infrastructure. And as those changes happen and as people disenroll or are disenrolled, what does that look like? And then, of course, the economic ripple effects that were also previously touched on. Those are real in communities, because for counties and for the local leaders, the electeds there, they care about everything because everything is their community and they are that very close touch point of government. I think I'm about out of time, but I love this presentation. I love this conversation. Look forward to questions.
All right, thank you. Thank you, Jacqueline. Okay, so I'm going to actually now invite everyone back on screen for some follow-up questions. Many of these questions were submitted ahead of time, so thank you all for doing that. I just also want to know, we are also trying to answer some of the Q&A questions live. And so some of them are being responded to in the system, and then we'll also try to answer some during this discussion as well. So I have some follow-up questions for each of you, and I am going to ask each of you to kind of keep it a little bit brief so that we can make sure to answer some of the additional questions that have been submitted. The first question I have is for Peggy. And, Peggy, we know that there's going to be a lot of impacts based on all of these federal and trickle-down state and now potentially county impacts. Can you say a bit about, what do you see as some of the lasting impacts on low-income communities due to these budget cuts and the dismantling of the safety net? And most importantly, what are some of the opportunities to minimize the harm?
Sure. So, I think some of the big risks have already been talked about, right? Fundamentally, people just won't be able to afford things. And that is on two levels. One, day to day. So when you think about being able to pay for food and other basic needs in real time. The other is not being able to handle a crisis should a crisis occur, especially when it comes to a healthcare crisis and the financial implications that that could lead to. We all know, those of us who were here pre-Affordable Care Act, that was always, like Jacqueline said, like that was always the data that we would put out is how much of a healthcare cost did it take, what was causing people to file for bankruptcy or get evicted and things like that. So that's huge. I think the other piece is the slide that Lisa showed around the shifts to states and the trade-offs. So if you lean into those trade-offs, right, states may not be able to invest in childcare the same way, in education the same way, in some of the housing pieces that states have started to do more and more in. States are going to have to make costs, even if they're able to figure out ways to raise revenues. So that's the big picture. I think what we're trying to think about when it comes to the harm is tracking it in three ways. Tracking the long-term harm, like any researcher does, like looking longitudinally, like over time, being able to show trends. But we also need to do more to track harm in real time. We can't wait 3 years for that year's census data to come out, right? We need to be able to track things in real time and then be able to tell stories of real families. So we're trying to think about how to organize the research and nonprofit communities in ways that can do that. There are a lot of opportunities to mitigate the harm. I think given time, I'll put some links to some things in the chat. But it is important. States do have choices or when it comes to implementation, and we want states to be able to lean into those choices and make the good, what we call the high road choices around ways to implement these things rather than the low road choices that could actually, they could use barriers to access to SNAP or Medicaid as ways to save even more money given the cost shifts.
Thank you. So helping us connect the dots. And that's actually a great tee up for a question I have for Chris, which is around what some of those choices are going to be. And so I'm wondering if you could speak to, what are some of the decisions and considerations that state policymakers are going to have to make as we head into the last week of the current session and as we look towards next year's budget? What comes next?
Yeah, I think in the very near term, I wouldn't expect very much from state leaders. They only have a few weeks left. They may make a few administrative tweaks to some things where they have clarity about what the implementation looks like. But as Lisa was outlining, there's a lot of places where that implementation is kind of murky. So I don't think they'll take too many preemptive moves yet. Bigger picture, I think the trade-offs are millions of people are about to lose their health care and their $120 a month food assistance. And so, as Peggy was saying, they will be worse off, and state leaders will be faced with the decision of whether to let that harm take effect in an already high cost of living state and an already difficult to make ends meet state, or whether to use the state's resources to make an investment to try to backfill some of the loss. There's no way they can do that without having a revenue and a tax policy conversation. We've never raised taxes at a level that it would require on a dollar for dollar basis to cover the potential federal losses. However, there are pathways, and the primary pathway is that the HR1 is basically those cuts are happening because we're giving away tax breaks that are overwhelmingly going to high wealth households and corporations. And so the pathway that seems most obvious is to claw back some of those tax decreases at the federal level, increase taxes at the state level, and use those tax revenues to provide health care and food assistance to Californians who would otherwise be losing their federal benefits. So that feels like the obvious pathway, but the political will to get there is an uphill battle right now. And I think that's the work of everyone that's here, just to try to figure out how to push state leaders to take bolder action.
Great, thank you. Thanks, Chris. So Lisa, the next question is for you. There's actually been a few questions in the Q&A around CalAIM, and we had teed up a question for you on this too. So I'm going to ask, how will the cuts impact CalAIM, enhanced care management, and community supports? And what are the considerations and opportunities, if any, for the next 1115 waiver?
That's an excellent question and something that is top of mind for a lot of folks. So there really is two things here when we're thinking about CalAIM. CalAIM is the state's current innovation waiver where we are trying to build out some new structures and programs to really support the most vulnerable within our Medi-Cal program. It is done through an 1115 waiver. That waiver is set to expire at the end of next year, December 31st, 2026, as well as our 1915B waiver. Those are the two primary waivers that the state used to get federal authorities to move forward with CalAIM. So what we do know at this point is the federal government is not touching those waivers. So the state has authority to continue the CalAIM initiatives, including enhanced care management and community supports, all the way through to December 31st, 2026. At the point when those two waivers expire, and before that point, the state will need to secure additional federal authorities to continue this work. What has transpired so far that we do know is the state has indicated that enhanced care management is being moved into the Medicaid managed care health plan authorities. It is a continuation of some of the current already existing requirements around care coordination and service supports. And so by baking it into the Medi-Cal managed care plan rates, there is an expectation that the plans will continue to fund enhanced care management moving forward through the health plan contracts. So that's one side of the house. On the other side of the house, community supports are done through an in lieu of service model. And so what that means is we have the authority to allow the plans to pay for these services that are preventative and supportive in lieu of something that is much more expensive, like a hospital stay. We have the authority to move that forward. However, until December 31st, 2026, the state has put out a concept paper where they're eliciting public feedback and comments. In this concept paper, the state lays out the history of 1115 waivers, how we got here as a state, why we're doing CalAIM, and is seeking continuance of all of the current authorities allow the state to do CalAIM. So that would include our in lieu of service requirements to continue community supports. Now, Having said that, depending on how big the state budget hole is and what happens more broadly around Medi-Cal will have an impact on these CalAIM programs, because you have to be enrolled in Medi-Cal before you are eligible for these programs in CalAIM. So if the total number of people in Medi-Cal shrinks down, will be fewer people eligible for these programs. So this is something that a lot of folks are watching carefully. What we can do is we'll pop the link to the concept paper in the chat. There is an opportunity for everybody to weigh in. Under waivers, states are required to seek public comments, and then after the state closes their public comment period and sends it to the federal government, CMS will also open period as well.
So much to be tracking. Thank you, Lisa. Jacqueline, one more question for you, and you touched on this a little bit in your comments. Our audience had questions about the impacts on rural counties and communities, and would love to know what you're hearing from those communities and what are considerations for local leaders to mitigate harm in those communities. And related to that, are you aware of any sort of county-specific analyses out there or in the works?
Yeah, so rural communities, as I did touch on briefly, it's a good question. They face unique challenges. They always have, that I had mentioned about, provider shortages, workforce issues, but a lot of times rural health systems are more reliant on Medi-Cal. I think it's almost universally true in the state of California. And so, one example I would give that we've been talking about a fair amount because it is so acute is Inyo County is around 19,000. It's Eastern Sierra for those who don't know. So south of Mammoth, it's got Bishop and Death Valley. They have the only, in Bishop, they have the only birthing center for 3 hours, like away, and like however many hundreds of whatever 100 miles it is to get there, and it's a money loser. Like there isn't one in Mono, there isn't one, in any surrounding area, and they are very concerned that with the number of Medi-Cal births they have, that disruptions to an already precarious health system have huge impacts. And so that's been really top of mind for them because it's not really feasible to tell people you need to travel 3 to 4 hours to deliver your baby. And that 3 to 4 hours is to LA. So, there's never any traffic there or time to be concerned about. And so it's really like the destabilization of the health system is particularly acute for rurals because if you're planning your budgets, and your budgets are small and they rely on a smaller number of patients, you can't try and paper over it. It's not going to be easy for anybody, but it's particularly challenging for them in those spaces. And when you asked about county specific data that's available, so the Berkeley Goldman School, specifically their Agile Public Policy Lab, which is fairly new, is in the process. We collaborated with them on a project that they are working on called Counties Rise. That features some good information around Medi-Cal, around HR1, and just sort of mostly around the Medi-Cal landscape and what does it look like now, sort of broadly statewide. They conducted a lot of county-specific interviews with county staff, county leaders, and really tried at public hospitals. They tried to get a lay of the land, and they have started developing county snapshots, and we don't have one for every county, and we're unlikely to. Our goal is to get to 20 counties and fairly soon. But we are trying to do county by county. What does it mean for them in their health system, economically, and also just sort of what does Medi-Cal mean in that county? And what does the safety net look like there? And they're pretty great snapshots, the ones that I've seen. And so I'll grab a link to the part of their website that's starting to publish those. But it is really helpful to kind of see it county by county and really appreciate that diversity and hopefully take that information and have people be able to paint a really full picture of California.
Great, thank you all. Okay, we're going to shift then to the audience questions. And I see, again, there's a number that have been answered in the Q&A. I'm going to go ahead and ask our presenters. So we'll try to get to as many as we can through the discussion today. There's a first question that I'm going to ask Peggy to speak to, which is around, do the eligibility requirements to access programs require both parents to have a social security number? Does it apply to single parent households? If so, what are the implications for all of those families?
So yes, it does apply to single parent households. So therefore, the single parent has to have a social security number, and so that could greatly impact kids who are citizen kids, and if their parents don't have a social security number or their parent.
Great. Thank you. And the second question, I'm going to punt, Chris, to you. It's Jeremy's question. You touched on this a little bit in your comments in the follow-up, but the question is, so Lisa highlighted the choice to increasing revenue versus cutting additional services. Is there any sense of where the thinking is now in Sacramento? It seems like given the cuts directly connected to the tax cuts for millionaires, there could be an opportunity for California to increase taxes on wealthy residents. So flagging that question for you.
Yeah, and I'll try to give you my best sense. In some ways, it's a sort of political landscape read and less of a policy landscape read. But I would say our state leaders are not in any consensus position yet around a conversation on tax policy. I think there's more chatter about needing to do something than there has been previously because it's now been made obvious that something needs to be done. But I think we have a relatively young, in terms of experience, state legislature, a lot of new folks, a lot of turnover over the last few cycles, a lot of folks who haven't governed through downturns or economic or other crises, and haven't had to address tax policy considerations as a result. And we also have a governor while who wants to champion an overall resistance to federal threats on many fronts, hasn't really have tax policy conversations either. So I think the tax conversation is one that needs a lot of outside pressure, to be honest, in order to move the needle, because there's not a lot of consensus or political will there yet. It's maybe building, there's maybe some momentum, but it needs a push. It needs some help.
So there's a related question too, also in the chat around how we can advocate or help, rather, how do we push for some of this bolder action? And so you just mentioned, Chris, there's some external pressure that's needed. Are there any thoughts we have on what some of the transformational moves are that California could make at this moment? And what some of that bolder action could look like? For any of our panelists.
Well, I'll jump in and say, I mean, I think it's a harder question on the Medi-Cal front, to be completely honest. I think on the food assistance front, where the state has a California food assistance program of its own that it's been using to provide food benefits to some immigrants who are not eligible for SNAP or for CalFresh, state leaders, if they could find the revenue, could stand up a more robust CFAP program and cover some of the folks who would be losing SNAP or CalFresh. So I think that could, that it's not super transformational, but it's a pathway that's actually readily available and money. I think it's a much more difficult question with Medi-Cal because there's so many complexities inside of the different technical aspects of it, from the work requirements to eligibility requirements to the MCO tax. How the state would respond and could it respond at scale has a lot more challenge to it. Just my initial take.
And I agree with Chris here. I do think and we think about transformation, Medi-Cal, it's sort of like Jenga. You pull out one block, you might, get the whole thing, it becomes a little wobbly. But, whenever there are big shifts like this, I always like to point out that threats can become opportunities too. And I think there is an opportunity, for example, if we're doing work requirements, is this an opportunity to build more pathways for those who do want to work, to support them into and lift and do warm handoffs into training programs? We have a lot of workforce gaps in the state that we do need support for. Are there ways to support how we help folks through this journey? And of course, ensuring that there are off ramps for those who really can't work and can demonstrate that. So I always think that in times like this, there's an opportunity here. It's not like some of our existing programming worked exactly the way we had hoped it to work there, or could, doesn't have room for improvement. So we can take this opportunity as a way of looking closely to all of our programs and create more linkages, more pathways to support folks locally.
Appreciate that, Lisa, because we need to have some hope in here too, and how we think about all of these complexities and challenges we're facing in a different way. I'm going to ask one last question, and then we'll move to the wrap up, which is oh, where did my last question go? Sorry. The questions are coming in fast and furious, so that's great. We're trying to answer as many online. So one last question is, if a family currently has Medi-Cal without a Social Security number, will they have to show proof of one for their next 6-month renewal? Do folks know the answer on that one?
So I don't think, not for the next one. So the way that the bill is implemented, there are staggered dates, and I can put a link in the chat to our web-based timeline. But so let's see, very few of the things we talked about, I think is the way to qualify it, take effect next year, if anything. Most things don't start till at least 2027. I can't believe we're already in 2027, but yes, so that's important to know that that very few changes, but very few changes take effect in the next fiscal year.
Great. Well, I know that we are adding links to resources in the chat too as we go. We're hitting right up against our time. And so I just want to wrap us up and say thank you to Peggy, Chris, Lisa, and Jacqueline for all of the rich information and insights that you shared. This has been such an incredibly heavy conversation, but also I know we're walking away with both content here as well as links and resources that we'll share afterwards. So deep appreciation to each of you for all of the work that you're doing every day on behalf of Californians and definitely all of our communities. To everyone who dialed in, thank you so much for joining us today. There's a lot to digest. And in this moment, I'll just say the California Endowment is also definitely leaning in and considering how we can best work together with our partners, many of you on the line, community organizations, advocates, and public institutions to continue to advance health equity across the state. As a reminder, we did record the webinar, and we'll be sharing the recording as well as all of the related materials, including slides and bios, to all of the registrants within the next day or two. And then lastly, we just wanted to make sure we get your feedback. And so please take a moment to fill out the survey. There's the QR code here. Please go ahead and scan the QR code. We've also, we'll put the link in the chat too. Let us know your thoughts on today's program and what topics we should be covering in the future. Thank you again, and hope to see you all at the next Policy Perspectives webinar. Thank you. This concludes our program.